I'm well aware I'm standing between us and lunch, and I'm the only nurse in the room. Feel a little set up. Thanks, Dan.
There's snacks.
Yeah. So, okay, why am I talking to you about what we did around nursing education in this session? We had a problem at Hopkins that I think many of us are experiencing nationally and internationally, which is that our health system is expanding, and our training programs are expanding, and our service area is growing pretty exponentially. So we went from a clinic that was treating about 100 patients, 120 patients at our main academic site, and 25 patients at our one satellite, to now treating between 300 and 350 patients per day at 5 clinics across the region. And our faculty are traveling, our residents are starting to travel, our nurses, our therapists, our physicists, and our IT infrastructure all had to kind of grow to accommodate that expansion. And what we learned very quickly is that you can't just transplant a faculty member from one site to another without developing the right workflows and understanding like the book of work that has to support that faculty member. And the same is true for your residency program. So that's why, so what I'm the director of nursing for the region for RADONC, and we had to figure out how to train our nursing teams to make sure that we were providing the same level of support at each of our clinics, which is a lot easier on paper than it is in real life, because we didn't take over clinics that were blank slates. We took over clinics that had staff that had been there for years and years. So we had to both bring on a ton of new staff to bring the staffing levels up to what we would consider standard. And that's a different kind of internal benchmarking project that we worked on. And then we also had to be able to train very quickly the staff who were there for a long time. So the opportunities that are a part of this kind of growth are obvious, right? Like getting our patients academic level care in community-based settings, being able to open up centers of excellence. So we don't treat thoracic patients anymore in our main academic campus. We treat them 7 miles down the street at Bayview at our second academic campus, which is kind of a big deal. Johns Hopkins Hospital, we don't radiate lung cancer patients at the main academic site anymore. So if you're gonna make that move, you actually have to make sure that everything that you're doing at your secondary location is exactly what you would be doing at the main academic site. So, the first thing that we needed to do is kind of identify what is our organizational structure as a multi-entity department. And in our entity, what that means is, in our health system, I have 4 different hospitals that independently negotiate the staffing arrangements for the staff in our department. So they're all regulated differently. We cross 2 different states now, which means we have different boards of health to deal with, different nurse practice acts to deal with. So we kind of had to identify what is our structure, what can I be in charge of directly, how can I hold people accountable, what does our management infrastructure look like. And I'll just kind of side note that everything that I did for nursing, we also had to do for physics and therapy and dosimetry and IT. So I'm just telling you about my piece, but this is just multiply this by 5 or 6. And then we had to identify a chain of command. And what that meant is getting my position replicated in everyone's organizational charts at every hospital across the system, and then having kind of a global org chart for the health system. We had to do that first, though, because unless we actually knew what the chain of command was for our department, no changes that we were going to put into place would actually stick. And this is, you can encourage people to utilize training all you want, but at some point they need to know that it matters so much that if they don't do their training, then there are going to be actual consequences in their daily life. So we had to do that first. We did a gap analysis, then we had to standardize our core competencies. What is that standard book of work for these clinicians? And then establish our process for continuous quality improvement. How do we make sure that the things that we're teaching aren't stale, that they're fresh, that they're based on evidence, and they're also based on some of the variations in practice that we're seeing in real life. So originally, like I said, each entity had its own organizational structure. The nurse manager on the ground at Sibley Hospital reported up directly to the director of nursing at Sibley, who reported up to the chief nursing officer at Sibley. And so we had to figure out how to insert a health system level director into that chain of command, which we did through a series of kind of negotiations at each entity. There's also a lack of formal reporting and accountability infrastructure in our own department, right? Like, how do we make sure that within our own department, I am personally responsible for our regulatory requirements at each of these entities. So when Joint Commission comes to Bayview, even though I work for the health system, I'm responsible for everything that happens in the department at Bayview. So that's great, but that also means you have to then know all of their kind of individual issues at each of them clinics. So we have to do a gap analysis. What's in place right now? How are they training staff right now? What are all of the regulatory and kind of hospital level requirements that will affect our department at each of the entities? Let's define that. Let's get it on paper. And then let's build a separate list of what we would like to see. You know, what are the things that we think, in addition to the minimum requirements for each site, what are the things that as a department we think should be on this list for kind of basic core competencies and regulatory competencies for every staff member in our profession. So our core competencies, we practice primary nursing, and so our nursing level core competencies involve toxicity management, patient education. Every nurse has to be involved in some kind of a continuous quality improvement project. We do cross-training around clinic-based procedures, so I think we're all kind of dealing with higher acuity brachytherapy procedures. We do adult anesthesia in our department now, which was a new gift from the last couple of years. But it's an incredible opportunity, you know, for our patients, but a huge lift for our nursing teams. So I had to cross-train a whole cohort of nurses in the OR, which they now have to spend about 6 months onboarding into OR procedures so that we can safely get these complex patients through the door in one day. And then we needed to figure out some way to manage acute toxicities. So we're doing an academic level head and neck program at a community-based clinic outside of Suburban Hospital. Some of you know Brandy Page, she's one of our fantastic faculty members, but she opened this really wonderful head and neck program in an office building, not attached to a hospital, you know, no kind of on-site airway management experts. We do endoscopes in the clinic, and they have to call 911 if a patient gets into trouble. So we had to figure out how to train this team to be able to manage everything up to an emergency in real time, but without all the bells and whistles that come with the hospital setting. That's great. Okay. And then continuously, like, how do we make sure that this basic set of work that we identified continues to be fed by our quality improvement process within the department, and then also from the larger kind of field of study? So we do that in a few ways. One of the things that we were able to do through our gap analysis is realize that we didn't have enough content expertise around nursing practice within the department, outside of me, quite honestly. So we advocated for and were able to negotiate a clinical nurse specialist position in the department. And for those of you who don't know what a CNS is, a clinical nurse specialist is a nurse who is an advanced practice provider who can, in some states, even write prescriptions and practice as an independent provider. But their job is to be a clinical expert, all things related to their subspecialty. And our clinical nurse expert practices at the health system level just like me. So I manage the staff, and anytime someone has a clinical issue in their actual practice, they email her, right? So an example, just one of the things she's working on this week is there was a question about, we have a patient coming in who I think is on TB precautions, who is getting an interstitial case done, and she needed to do the legwork to figure out what are the special, how are we going to actually run our anesthesia case with the patient who has an active infection. So things like that, where it would totally potentially derail a patient's treatment or derail a clinic. Like I couldn't just drop everything and figure out how to do this, but I have somebody who is identified that everyone knows about who can be that person. And then she feeds all that evidence back into the system, and now we have a policy about how to do that. So that is what we did. Because we were able to establish this book of work that includes a package of training when we're onboarding people with orientation, because you have to get them when they're coming in the door. They never properly socialize, into your expectations. We also have a book of work around annual competencies that Jen, our clinical nurse specialist, is in charge of. So she writes the competencies for all of our sites and then travels around. We call it our travel and roadshow to make sure that everyone is trained in a structured and standardized way, but based on what we're seeing from our safety reports in the department. I believe, and I don't have good evidence for this, but I believe it's enabled for much smoother transitions from one clinic to another. I think that when our residents travel from one site to another, when our faculty travel from one site to another, they know what they're getting. They know exactly what that nurse is capable of when they show up in the new clinic, and they know what their expectations are about how the clinic is going to run, who's going to manage toxicities, who's going to take the phone calls, how am I going to get my order signed, how am I going to negotiate to get a patient, directly admitted to the floor. We've identified that, as a part of the work, and I think that actually allows them to practice, their highest level when they get where they're going. And that's basically it. I'm sure I'm over time because I always run over, but I'm happy to answer any questions about this, and
So